Hello everybody and welcome to this tutorial. My name is Dr. Ben and I hope you are doing very well. Today's tutorial is about these five diseases. We were talking about tuberculosis, typhoid, COVID, malaria, and traumatic brain injury. So as you know, in case of tuberculosis, we have primary tuberculosis, miliary tuberculosis, and post-primary tuberculosis. In case of primary tuberculosis, the initial focus of infection can be located anywhere within the lung and has no specific appearance, ranging from too small to be detectable to patched areas of consolidation or even a lower consolidation. Radiographic evidence of parenchyma infection is seen in 70% of children and 90% of adults. Cavitations in this stage is very uncommon, but it's seen only between 10 to 30% of the cases. In the majority of the cases, the infection becomes localized and forms the tuberculoma, which usually eventually calcifies and is then known as gone lesion. The more striking finding, especially in children, is that of ipsilateral hilar and contagious mediastinal lymphadenopathy, usually right-sided. The pattern is seen in over 90% of the cases of childhood primary TB, but only between 10 to 30% of the adults. These nodes typically have low density centers with ring enhancement on CT. So you can see here this defined in case of adults, defined patio or opacifications. In this case, your left side you can see this right upper lobe opacification and your left side both lower lobes opacification. In this case, we are seeing a sample of the tuberculoma or the gone lesion, which is marked with a red arrow, and multiple left and right bilateral buds more visible on the left side. Or these are round or oval masses suggestive of the calcified nodules, which is marked with a black arrow. Then we have this miliary tuberculosis, which is uncommon but carries a poor prognosis. Miliary deposits appear as 1 to 3 millimeters diameter nodules, which are uniform in size and uniformly distributed. If the treatment is successful, no residual abnormalities remain. That's very important to know. If the treatment is successful, no residual abnormality remain. Remember, this is pattern of multiple and bilateral micronodular lesions, like this one, from 1 to 3 millimeters, uniformly distributed. It's a classic image. We have another 4 or 5 differentials for this one, but it's not the main focus on this tutorial. Now remember, you need to have in consideration the history of the patient and the lab test, in this case, to confirm your final diagnosis. That's very important to know. And then we have the post-primary TB, in which the lesion should be located in the posterior segment of the upper lobes and the superior segment of the lower lobes. The post-primary TB go to produce a different type of radiological lesions, maybe in the parenchyma or in the pleura. In the parenchyma, go to produce this ill-defined patchy consolidation. Also go to produce cavitations, which go to develop within the consolidations. And the healing results in fibrosis. The healing of these lesions results in fibrosis. which go to lead to bronchiectasis and atelectasis. So at the pleural level, go to produce pleural effusion, pleural thickening, and pleural calcification. And this is a sample of the kind of the diseases. In your left side, you can see this a defined patches of pacification in the right upper lobe with cavitations within this lesion. And on your right side, you will see this healing process, which is producing fibrosis of the left upper lobe and loss of volume of that lobe, producing atelectasis in this area. Spine manifestations. So tuberculosis of the spine or Pott's disease is the most common site of the bone infection in case of TB. Hips and knees are also often affected. The lower thoracic and upper lumbar vertebrae are the areas of the spine most often affected. The lower thoracic and upper lumbar areas are the most common affected in this case. In plain X-rays, tuberculosis spondylitis can be difficult to detect in early stage because of the relative preservation of the disc space. A reduction in the vertebral height is often seen with the irregularity of the anterior superior end plate being relatively early in and subtle sign. Also, you can find irregularity of the anterior vertebral margin, which is a classical appearance with TB spondylitis. But what happens in some cases? In the majority of the cases, this early stage of the Pott disease, there should be young people who will come into your consulting room with back pain. When you go for the X-rays, in the majority of the cases, the X-ray is negative. But what happens? You have to put a special attention to the soft tissue and look for any density variation in this case, and then look for these subtle signs or bone erosion or any end plate sign or end plate sclerosis can guide you to your, in this case, this type of terrible disease. So you have to pay attention on that and always back up with a lab test. Always back up with the lab test. But first, you have to think on this kind of the disease. Otherwise, you will not able to diagnose Pott's disease. It's as simple as that. And then when the patient comes a few months later, it's too late, because sometimes they are coming with damage already of the spinal cord. So it's very important to try to diagnose this type of the disease in the early stage. And here in West Africa, it's very common. It's very common. So these are a sample of the Pott disease or tuberculosis spondylitis. So you can see there is a total vertebral destruction in some cases with fusion of the vertebral bodies. Total vertebral destruction with fusion of the vertebral bodies, and the physical examination you go to appear this kind of kyphosis. In other cases, you're going to see this huge paravertebral abscess. These cases are easy to diagnose, but like I say, the trick is to diagnose the disease in the early stage so we can avoid any damage with the correct treatment to this patient. So for further investigation, we use cross-sectional imaging to assess better the extension and involvement and particularity for the presence of any epidural component and cold compression. MRI is the modality of choice for this case, with CT with contrast being a distant second. Features include irregularity of both the end plate and anterior aspect of the vertebral bodies with bone marrow, edema, and enhancement seen on an MRI. The paraspinal collections are typically well circumscribed with fluid centers and well-defined enhancement margins. So this is a sample of the MRI. You remember, they go to attack the lower part of the thoracic vertebral bodies are made from T10 to T12. The upper part of the lumbosacral spine that mean between L1 and L2. So just pay attention. You have to be able to diagnose this terrible disease in the early stage so you can save the patient. Intraperitoneal manifestations. Tuberculous peritonitis is a form of extrapulmonary tuberculosis affecting the peritoneum. It is frequently seen in association with other forms of gastrointestinal tuberculosis. Radiological signs include ultrasound, in which we are going to see a diffuse peritoneal thickening, ascites, adhesions, omental and mesenteric thickening, increased bowel wall thickness, and lymphadenopathies. So these are sample what you're going to see in the ultrasound. You can see this large amount of free fluid in the intraabdominal cavity. So it's basically when you request for the ultrasound, so you were to receive this report with this large amount of fluid, sometimes with the majority of the cases with sectations. So when you receive this, depending on the clinical, like I always say, clinical history of the patient and the lab test, you can be sure, almost be sure, you are in the presence of intraperitoneal tuberculosis. It's very important to know. Eventually, you also can request, depending on where you are, a CT scan. The CT scan will to show something similar, but in this case, we want to see more with more details the pathology. So we are going to see a nodular or symmetrical thickening of the peritoneum and mesentery, a normal peritoneal or mesenteric enhancement, ascites, and enlarged hypodense lymph nodes. In addition to this, there can be more specific imaging features seen with individual types. We have the wet type, dry type, and fibrotic type, just for your general knowledge. So this is a sample of the CT scan. We can see this large amount of free fluid, all these hypodense areas. In this case, loculated areas. So remember, in case of the intraabdominal tuberculosis, you will receive this report of this large amount of free fluid. We're talking about the peritoneum, specifically about the peritoneum, because we have also a renal tuberculosis. You can see this a calcification within the kidney, and sometimes you can see also the ureter is calcified. It's calcified, but it's more common in the peritoneum. Here in this part of the world, is more common in the peritoneum. In Ghana, we see a lot of cases with this kind of tuberculosis manifestation. So you always you have this patient with ascites, you always think in this tuberculosis infection. So typhoid. So everybody knows very well what is a typhoid fever. It's a very common disease in West Africa. In this case, of the ultrasound findings, we are going to find splenomegaly, bowel wall thickening, mesenteric lymphadenopathy, hepatomegaly with normal parenchymal pattern, thickening of gallbladder, biliary slash, positive ultrasound Murphy's sign, pericholectic edema with increased vascularity, and mucosa ulceration in the wall of the gallbladder. these are some of the ultrasound findings. So in this case, we can see that this also is this lymph node, intra-abdominal cavity. We have the splenomegaly. We have this calculus glossitis and the edematous mural thickening of the bowels. So what happened with this case? Sometimes you request for you have this patient with this abdominal pain, with this maybe it's moderate, so there is no any complication yet, and you request for ultrasound, and you will find in your report this mucosa thickening of the bowels, maybe a small or large bowel. So you have to think there is some kind of infection, the enteritis. So in this case, because the more common is typhoid, part of the lab test, which you confirm your final diagnosis, you have to think in this kind of infection. In the CT, it's very similar, the findings. So you find the enteritis, colitis, or also mesenteric adenopathies. Also, you can find sign of gastrointestinal bleeding, gastrointestinal perforation, but also ascites, acute calculus cholecystitis, ascending cholangitis, and splenomegaly. So these are examples of the CT we can confirm with this large white arrow the thickening of the right colon. So in this case, it's specific for the typhoid. So when there is any bowel thickening, you have to think in this kind of infection here in West Africa. So what is the most important with this is the complication they can produce. The most common in this case is perforation. So you know when this you have this bowel injury, that the perforated bowel, they go to release they're going to release intraluminal content and A. So they can produce a peritonitis, which in majority of the cases can become severe. And then at the same time, we're to produce pneumoperitoneum, which you have to you receive this patient with this severe abdominal pain. Usually, you are seeing a lot in your OPD. So in this case, you have to request for the chest X-ray and ultrasound at the same time. So with the ultrasound, we are able to localize the intra-abdominal fluid, and also we are going to see different signs of the intra-abdominal A. They can guide the radiology of the ultrasonographer to think there is some kind of peritoneum, of pneumoperitoneum. So in this case, we will to confirm with this chest X-ray. In case of the chest X-ray, you are going to see this amount, or maybe mild, moderate, or maybe a large amount of free air under the diaphragm, maybe right or left, or maybe in both. Or remember, always they were to appear first in the right side, above the liver. Also, you have also take in consideration uh, other differential diagnosis of of the pneumoperitoneum, like cheilitis syndrome, atelectasis, meteorism, and right subphrenic intra-abdominal abscess. So you have to take this in consideration. Remember that depends also the history, the physical examination of the patient. Like I always say, remember medicine is history, physical examination, your impression, and then you confirm your impression with the tests, maybe lab tests or radiological tests. Okay, so always remain that, always think in that. So ultrasound and chest X-ray. Now there is another signs, that different signs on the chest. In this chest X-ray, also there are different signs. Abdominal X-ray can guide you that can guide you to this intraperitonean gas. This intraperitonean gas, which is a more advanced, but you can look at it. For example, this is the free gas, double sign, and the coitus abdomen sign, and the regular sign. You have to know these four. You have to know these four very well. Then the rest you can look at it. Even this is the pediatric age, the football sign. So you have to look at it. So because this is for the all age. Remember that it's for the all age. So this disease is very common where you have to put the attention to it. Because why? Because if you cannot able to diagnose this kind of the disease, the patient can die. The patient can die. So it's very important to know very well the physical examination, the clinic, and the text, radiological test, and what to find any of these texts. Okay, so this is another example of the regular sign. In this case, abdominal X-rays and CT scan of the abdomen. So you have to look at it very well, and remember, always suspect in this kind of the diseases. Okay, so now let's go talk about COVID. So you know the concept and everything about COVID, but let's go to be specific about the radiological features in this case. So the chest X-ray is less sensitive than the chest CT scan, but the chest X-ray is typically the first line imaging modality used for patients with suspected COVID. So what happens in the chest X-ray? Usually in the chest X-ray can be normal in early or mild diseases, okay? But the most frequent findings are bilateral opacities. Bilateral opacities. That's the most important thing you want to see in the chest X-ray. Also in the chest X-ray, you can find some cardiac manifestations which are well recognized, but there is no published so far at this time with evidence of the cardiac disease. Okay, but that's for adults, but for children, so at the pediatric age, the approach is different. So the pediatric age, sometimes the chest X-ray, they see the lamps are negative at all. There is no sign of this bilateral opacities, but this patient have this cardiomegaly. Okay, so sometimes you have this pediatric age patients with respiratory symptoms, but the lamps are clear, but they have this cardiomegaly. You have to suspect the COVID-19. It's very important for you to know that. This cardiomegaly is more frequent in children than adults so far. So these are a sample of the chest X-ray. You can see this is a bilateral opacity, like a bilateral pneumonia. It's the most frequent sign, radiological sign, in case of the COVID in the chest X-ray. It's very important for you to know that. When you see this well-defined or well-visible opacities in both lamps, you have to suspect immediately, oh, this is COVID pneumonia. Okay, it is COVID pneumonia. Always keep in your mind and that. Now, as you go to CT, in case of the CT, the primary CT findings would to be a ground glass opacities, crazy paving appearance, area space consolidation, bronchovascular thickening, and traction bronchiectasis. Now, in case of the ground glass appearance, these are the usually bilateral, peripheral, and basal. That you have to know about the ground glass apparent with the more common sign on the CT scan is they are peripheral, they are bilateral, and they are basal in distribution. They are basal in distribution. Okay, that's very important to know for you. Now, another atypical CT finding, we have myasthenia lymphadenopathy, pleural effusion. We have pulmonary nodules, pneumothorax cavitations, and pneumomyasthenia. That's very atypical. Now, but what happens in CT scan? In the CT scan, we have 4 stages of the disease. The first stage is the early stage. It is between 0 to 4 days, which can be a normal CT scan, or yeah, this is a ground glass opacity only. We have the progressive stage, which is from 5 to 8 days, with the increase the ground glass opacity and decreasing paving appearance. We have the peak stage, which is the 9 to 13 days, which we have this franky consolidation. And the absorption stage is after 2 weeks. That is the patient survive. We have the improvement in the disease course. We want to see these fibrous stripes. Which can lead to some bronchial dilatations because of fibrosis. And the abnormalities resolve at 1 month and beyond. But you have to be very careful. Now, so some patients with this the post-COVID syndrome, which in which case they have their symptoms, they are still coughing, they have fever, but the PCR are negative. Even they repeat 3-4 times, the PCR are negative, but the chest X-ray and the CT scan are positive. So in this kind of patients, where the CT scan is positive or the chest X-ray, you always have to think in this post-COVID syndrome. Okay, this post-COVID syndrome. There is no matter if the PCR is negative. Always think in this post-COVID syndrome. Remember, this is a novel disease. All the study have not done yet. So these are a sample of the one patient with ground glass opacities. You can see they are bilateral, peripheral, and basals. Always remember that. And this is another sample of this disease. This is yes, for the 4th stage. We want to appeal this fibrous stripes. The fibrous stripes want to produce these bronchial dilatations. Okay, so when you see this patient with the post-COVID syndrome, that's what we're talking about. The CT scan goes to appeal like in this case. Okay, and remember, this is patient. The majority, the patients are very old. We survived COVID, but they continue with symptoms after a certain period of time. But the PCR is negative, so you have to suspect always this is a COVID case. Okay, let's talk about malaria, which is a very known disease here in West Africa. The most common finding ultrasound is the pathosplenomegaly, and in case of B scan or I scan, there have done a lot of research about the measurement of the optic nerve shift, which is very precise. There are a lot of research, and it can give you good reference about the diagnosis and the complication of the malaria. In this case, it was cerebral malaria. So when you have present the cerebral malaria, we are going to see in this B scan where you can request from any part. But it's very important to know. So when you suspect cerebral malaria, you have to request for B scan, and the ultrasonographer or radiographer should be able to perform the kind of this scan and give you the exact dimension of the nerve shift. Is very important for you, which the diameter is about 2 to 3 millimeters. Okay, above of that, so you consider there is some serious damage in the nervous system. Second to malaria, that's very important for you. For malaria, the majority of the cases you know is blood test, history of the patient, physical examination. Just ultrasound is complementary, but like I say in this case, the B scan is very important. But also you can request chest X-ray. In the majority of the chest X-ray, you want to see this marking lumps increase. You also in the majority of the cases you want to see this bilateral acute pulmonary bilateral pulmonary edema. Bilateral pulmonary edema with this radiological signs of bat wing or butterfly sign, which is very is specific for this kind of disease, pulmonary edema. So it's the more common side you're going to see in the chest X-ray. Also, when you see a CT scan, it's also most of the same. For general, they can produce a cardiac failure, and then they can produce this acute pulmonary edema. It's more important to know. We are talking about malaria on the chest. Also, we can combine this cardiac failure also with pleural effusion. Okay, so you have to be in mind when you request for chest X-ray, we increase the marking of the lumps. The second is this acute pulmonary edema, and the third is maybe pleural effusion. Now, in case of cerebral malaria, you have to request for a CT scan as well. That's combined with this ultrasound. I mean, you have done the ultrasound, you are suspecting cerebral malaria, you are on the treatment, and then you want to know more about the patient. You have the possibility to request for CT scan. So you are request CT scan, and maybe you go to find cerebral edema, thalamic hypotension, and cerebral white matter hypotension from infant, and sometimes it can be normal, and the patient can have cerebral malaria. So also you have to rule out that. So negative CT scan that don't mean the patient doesn't have cerebral malaria. Okay, but all we have to request for the B scan. I think it's more predictable the diameter of the nerve shift than the CT scan itself. Okay. Also, the MRI is very good in this case. It's very important, but there are all facilities that we can provide MRI. Okay, so I think it's more based in your experience, the history of the patient. You always have to think in malaria. The patient is complicated, always think in cerebral malaria. Okay, always think in cerebral malaria. So I think it's a more clinical situation. So put the patient on the treatment, and then we request for the complementary studies. Okay. Okay, so this is our last chapter, traumatic brain injury. So the traumatic brain injury is a major cause of morbidity and mortality worldwide. They can broadly divided into close and penetrating. So in this case, we are to be focused on the close head injury, which is the most common. We have the blunt trauma, that means a motor vehicle collision, assault, sport, industrial workplace accidents, etc. Blast injury and non-accidental injury in children. So what is important, this is about the clinical presentation, which is present with a combination of reduced Glasgow coma scale. We have the mild trauma brain injury with the Glasgow is between 14 to 15, moderate traumatic brain injury with the Glasgow 9 to 13, and a severe traumatic brain injury with the Glasgow from 3 to 8. Now, talking about the pathology we find in the studies, in this case of traumatic brain injury, we have a traumatic subarachnoid hemorrhage, subdural hematoma, extradural hematoma, intraventricular hemorrhage, cerebral hemorrhage contusion, and diffuse axonal injury. But this is very important to know. Also, a secondary brain damage can also occur and manifest as generalized cerebral edema, hypoxic and ischemic brain injury, and ischemic stroke. Now, sometimes the doctors, medical students, they forgot about the associations of these brain injuries. Okay, so when you have this traumatic brain injury, you have to be sure the patient doesn't have any cervical spine injury. You have to look for skull fracture, facial fracture, also pneumoencephalus, and you think there is also extracranial injuries, will represent 35% of the cases. Now, I think there is a misdiagnosed with the axonal injury. So I think the majority of the doctor, even they don't think in the axonal injury. But for you to know the axonal injury which is affecting organized white matter tracts, okay, as corpus callosum, internal capsule, dorsal membrane or pons, or the gray white matter interface, particularly in the frontal lobes. It's more sensitively detected on MRI. Well, as we know, in all the hospital here in Ghana, we have the presence of the MRI, but we can continue requesting for CT scan. And also, axonal injury can be hemorrhagic or non-hemorrhagic, and it's divided in different grades. We have grade 1, which involve subcortical white matter. Grade 2 involve corpus callosum, and grade 3 involve the brainstem. And the thalamic lesions are not included in grading system, but are associated with a poor prognosis when it's present. Anyway, the radiologist should be able to give you the different grade for the axonal injury in case we have a patient with this kind of pathology. So this is an example of this type of the axonal injury, where we see extensive gray, white, and matter junction regions of abnormalities in this case. Okay, you have to see all hypodense areas between the white and gray matter. So that's very important. Always think in this axonal injury. Even sometimes the CT scan will be available for us. Is the CT scan. Sometimes the CT scan can appear negative, but also the pain of the experience of the radiology, which is reporting this kind of this traumatic brain injury. So sometimes that to be just very subtle and difficult to diagnose, but you have to think always on that. So the CT scan is the workhorse of imaging in the traumatic brain injury, especially in the acute setting. It is able to identify the majority of the injuries at the time of presentation. It is common for multiple injuries to be present simultaneously, such as the combination of cerebral contusion and traumatic subarachnoid, subdural, or extradural hemorrhage, as well as skull fracture and facial fracture. The MRI has a supplementary role in this case. So we are present this like this one, this multiple cerebral contusions and temporal bone fracture. With this case, you can see fracture. In this case, you can see this well-defined cerebral contusions. This is another example of traumatic brain injury. In this case, we are in the presence of the intracranial hemorrhage. Okay, these are these hyperdense areas, which is a fresh blood surrounding with these hypodense areas. We are in the presence of edema. And the more important, we always have to think is the epidural and subdural hematoma. And we have to know the radiological difference between epidural and subdural hematoma. Why? because the subdural hematoma can kill the patient. So if you don't know how to diagnose or make the difference between epidural and subdural hematoma, maybe you are killing the patient yourself. Okay, so subdural hematoma is an emergency. You have to send immediately to the theater for the evacuation of this type of hematoma. All right. So just put in mind, subdural hematoma is an emergency, and you have to know very well the difference between epidural and subdural. So I think that's everything for this tutorial. We just pass for review these 5 the diseases were you able to. I think we just review these 5 subjects which are very important, very common in your daily medical practice here in the here in Ghana, because I think they are very important for you to know that. So I will see you in the next tutorial.